Hi, everyone, and welcome to DAS Health's webinar, MIPS and CHIPS Lunch and Learn for the Cost category. My name is Lindsay Lanning, and I lead our government incentives team for DAS Health. Now, before I get started, I want to take a moment to explain the process for today's presentation. First, I want to mention that this webinar will be recorded, and we will send out a copy of the slides and recording within the next week. Next, for those of you who aren't familiar with DAS Health, I encourage you to visit our website, connect with us on LinkedIn, and subscribe to our YouTube channel, all of which are linked here on the screen. And again, when we send out this copy of the slides, you'll be able to link those there. And here you can access all of our historical webinars on our YouTube channel, and we always post about upcoming webinars on our LinkedIn page. I also want to mention a few of our upcoming webinars. So this is our last installment of our MIPS and CHIPS Lunch and Learn series, but we have plenty of topics to cover after this. First, for any of those who are interested in remote patient monitoring or chronic care management, we will actually be hosting a webinar that will explore how to use these two services to actually maximize your MIPS reimbursement and also use the extra ROI to pay for MIPS assistance. We have several clients now who have RPM, CCM, and MIPS assistance with us because of how easily they can pay for each other and leave your practice with higher reimbursement from higher quality scores and added services that are billable each month, so a win-win. We will also be doing a webinar on the proposed 2024 MIPS changes that should be released in the coming weeks. We're not sure if that'll be July or August, but we will announce this date for that webinar, as soon as it's released. Again, we'll be sending out an invitation to each of these webinars a week or so before, and we always post on our LinkedIn page as a reminder. So keep your eyes peeled for both of those. Okay, so back to today's webinar, our last one focused on the cost category as part of our MIPS and CHIPS Lunch and Learn series. So at the end of the presentation, we're going to open up the floor for questions from you. We will answer all questions at the end, but you may type them in the questions area of the webinar control panel whenever they occur to you. And then finally, for audio clarity purposes, everyone's phone will remain muted throughout the entire webinar. If you experience any audio issues, please use the chat box to let us know so we can help resolve them. And again, questions may be entered in the questions box. So without further delay, I'd like to introduce my team who will be your presenters today. Myself, Lindsay Lanning, DAS Health Government Incentives Manager, and my amazing government incentives consultants, Bridget Peterson and Kimmy Watson. We all have been working with MIPS since its inception, as well as the legacy programs, as well as PCMH and many other quality reporting programs for years. And we each have our own areas of expertise, either with the different programs or different EHRs or registries. And we're excited to help your practice in any way we can. So Bridget, we're going to start with you. The webinar is all yours. Feel free to get started whenever you're ready.
Great. Thank you, Lindsay. Okay, thank you everyone for joining us on this Wednesday afternoon for our deep dive into the cost category. The idea is to provide a greater number of webinars that are a bit shorter and a little less content all at once, so that this makes MIPS more digestible, which was actually a request from one of you on our YouTube channel. However, before we can get started, we have to share the recent announcement made by CMS. If you are not on the CMS listserv, you may have missed that they officially announced the COVID-19 hardship for 2023. We were very unsure if they would allow this hardship again in 2023 since the public health emergency ends this year, but it looks like they have moved forward with this again. Now, I'm hoping I don't see our numbers just plummet off the call right now, because while yes, this would allow you not to report in 2023 and not receive a penalty, it also allows you to report only 2 categories and exclude from cost for a full score, which is huge. This means we get to go into submission picking either PI or quality and knowing exactly what our score would be when we submit. We will not have these flexibilities in future years, and there are Medicare reimbursement cuts going into effect. So our recommendation is to participate and try to offset these cuts by earning a high score. You can apply for this hardship on your QPP portal just as previous years, but don't forget, if you apply for the hardship, any data you submit or that is submitted on your behalf will override reweighting for that performance category, and the category will be scored. Okay, so back to today's presentation. If you were able to attend our other Lunch and Learn webinars, we did include an overview of MIPS, which you can view this on our YouTube channel, or we can send you the link. But for this presentation, we want to get right into the cost category. But just in case anyone is brand new to MIPS on the line, we do have 2 quick slides to explain where and how the cost category fits into this program. So the merit-based incentives payment system, or MIPS track, is what we are talking about today. It was developed to improve patient health outcomes by tying payments into quality and cost-efficient care with the intention to increase the use of healthcare information and reduce the cost of care. And believe me, we know that MIPS sometimes gets a bad rap. It's just another set of requirements. It's more clicks or burdensome workflows, and I hear you. But at its core, this program does work to improve patient care and outcomes. Because frankly, if you are following the workflows, you are likely performing more screenings and taking extra steps to provide education, follow-up plans, or necessary referrals. And you're documenting it so it can be shared with other providers and practices. On the administrative side, this program consolidated all the legacy programs that we used to have to report on into one. So we used to have PQRS, value-based modifier, and meaningful use, and now we just have MIPS, which each one of those legacy programs aligns with the category under the current program. But today we'll be focusing on the VBM portion of these legacy programs. So under MIPS, you are required to submit data on 4 categories. 3 of which I already mentioned: the quality, promoting interoperability, improvement activities, and lastly, cost. So the quality category is basically the old PQRS program. This category is going to consist of quality measures like documentation of current meds, blood pressure, your tobacco cessation, depression screenings, diabetes, eye exam, etc. And the promoting interoperability, the PI category, is the old meaningful use program, and it contains the measures like e-prescribing and patient portal access. Then we have improvement activities. This is actually the only category under MIPS that did not stem from a legacy program and is completely new. And finally, the cost category, which is the old value-based modifier program that measures spending and utilization for practices. So your performance across the MIPS categories, each with the specific weights, which you can see on the screen, will result in a MIPS final score of 0 to 100 points. Your MIPS final score will determine whether you receive a negative, neutral, or positive payment MIPS adjustment. Your MIPS payment adjustment is based on your performance during the 2023 performance year and applied to payments for your Medicare Part B covered professional services beginning on January 1st of 2025. So again, we know that spiel should sound familiar, but now let's get into the good stuff and review what's required for cost. So the cost category is intended to assess performance among clinicians in terms of their cost efficiency. And reviewing cost performance can inform clinicians on costs related to many things, such as inpatient hospitalization, costs related to the management of certain conditions, or the overall cost of care delivered to a patient, with a focus on primary care. The cost category is worth 30% of your final score, and it is scored through the entire 12-month reporting period starting January 1st through December 31st of 2023. The cost measures are calculated using Medicare administrative claims data, which means you do not have to submit any data for this performance category when reporting like traditional MIPS. So you will not have to run reports or upload any data because CMS uses Medicare claims to calculate cost measure performance. Physicians must meet the case minimum requirements for each measure in order to have the measure count towards the cost category performance score. If the case minimum is not met for a measure, then the cost category weight will be based solely on the remaining measures. If the case minimum is not met for all cost measures, then the cost category will be re-rated to 0%, and that 30% will be distributed to another performance category or across multiple categories. The score for the cost category will be determined using an approach that is similar to what is used for the quality category measures. Physicians will receive 1 to 10 points for each of the applicable cost measures based on their relative performance in the measures compared to the measures benchmarks. Now, unlike the quality category, physicians will not automatically receive a minimum number of points for these measures. Additionally, unlike the quality category measures benchmarks, the cost category measure benchmarks are not based on previous year's data. Cost category measure benchmarks are determined using this year, the performance year data, and seeing how physicians performed compared to their peers. CMS established a maximum cost improvement score of 1 percentage point out of 100 percentage points available for the cost performance category. So a total of 25 cost measures are available to evaluate cost category performance in the 2023 MIPS performance year. It's similar to quality in that each measure is worth 10 points, but don't worry, you aren't scored on all 25. There are 2 that are almost all practices are scored on, which are the Medicare spending per beneficiary and total per capita cost. And the rest are all episode-based measures that will depend on your specialty. You can see a more detailed breakdown of the measures here. The first 2 are population-based measures. TPCC assesses the overall cost of care delivered to a Medicare patient with a focus on primary care received. MSPB assesses the cost of care for services related to qualifying inpatient hospital stays, which can be immediately, prior to, during, and after for that Medicare patient. And then the 23 episode-based measures are broken down either by procedure, acute conditions, or chronic conditions. One thing to note is that these measures are focused on Medicare Part A and B claims data. No other private payer data is included in these. And it's not just Part B, which a lot of people may assume since the MIPS payment adjustment only applies to Part B. Now, before we get started into each measure, there are some basics you need to know. For cost measures, certain features apply, which first is payment standardization, the process of calculating standardized payment amounts that allow for the measurement and analysis of clinician resource used by CMS and researchers. Payments included in MIPS cost measures are payment standardized. Next is the benchmarks. CMS calculates a single national benchmark for each cost measure, which are based on the performance year, not a historical baseline period. All MIPS eligible clinicians that meet or exceed the case minimum requirement for a measure are included in the same benchmark. And again, this is different than the quality benchmarks, which are created on a historical data from 2 years ago. You will be judged against your peers for that specific year. Attribution. Calculation of claims-based measures requires the attribution or assignment of patients' treatment costs to clinicians so that those costs can be evaluated through a specific measure. Each measure employs its own attribution method, described in the details in the 2023 cost measure information forms for each measure, and these are measure specific. And then you have risk adjustment, and this accounts for differences in patients' characteristics, which means they account for variation in clinician costs. So for example, it's going to take into account patient age, comorbidities, and other factors so that only the costs that the clinicians can reasonably influence are included. And we want to point out this shouldn't be confused with the complex patient bonus added to your total MIPS composite score at the end. I will go ahead and turn it over to Kimmy, and she's going to take us through the actual measures that I just mentioned. Kimmy, it's all yours.
Thanks, Bridget, for that enlightening intro into cost basics. Now that we have an understanding of what cost is looking at, let's take some time to measures that are available to choose from. The MSPB clinician measure focuses on inpatient care. It assesses the cost of Medicare for Parts A and B services provided to a patient during an episode, which comprises the period immediately prior to, during, and following a hospital stay. Specifically, an episode includes Medicare Part A and Part B claims with a start date between 3 days prior to a hospital admission through 30 days after hospital discharge, excluding a defined list of services that are unlikely to be influenced by the clinician's care decisions and are considered unrelated to the hospital admission. Medical episodes are attributed to clinicians in 2 steps. One, the episode is first attributed to the tax identification number, the TIN, that billed at least 30% of the inpatient evaluation and management services listed on Part B physician supplier claims during the inpatient stay. And 2, the episode is then attributed to any clinician in the TIN who billed at least one inpatient E&M service. Surgical episodes are attributed to any clinicians who performed any related surgical procedures during the inpatient stay and to the TIN under which the clinicians billed for the procedure. For exclusions for the MSPB, patients are excluded from the MSPB clinician measure if they weren't continuously enrolled in Medicare Part A and B claims from 90 days before the episode start date through 30 days after discharge. And they're excluded if the patient has a primary payer other than Medicare or is currently enrolled in Medicare Part C for any time during the episode window or the 90-day look-back period prior to that start date. Patients are excluded if there's no main clinician is attributed to the episode. The patients are also excluded if the patient's date of birth is missing from the source data, or patients are excluded if the discharge of the inpatient stay occurred in the last 30 days of the performance period. And the final exclusion is the patients are excluded if the patient's death date occurred during or before the episode. So episodes are excluded from the MSPB clinician measure if the index admission 1 didn't occur in subsection D of the hospital paid under the IPPS for acute care hospital in Maryland, and then also if they were involved in an acute hospital transfer. So let's say you have patients that meet all of these exclusions. How many cases will you need to report for this cost measure? The case minimum for the MSPB clinician measures is 35, which means 35 total MSPB clinician episodes must be attributed to a MIPS eligible clinician or group for the measure to be scored. For groups, a total of 35 MSPB clinician episodes must be attributed across all MIPS eligible clinicians who have reassigned their billing rights to the group's TIN. And then finally, a clinician participating in MIPS as an individual won't receive an MSPB clinician measured score if the clinician doesn't bill Medicare Part B physician supplier services furnished to patients during hospital stays and therefore doesn't meet the case minimum. With at least 35 cases, we can move on to how we could calculate your score for this measure. The MSPB clinician measure is calculated in 6 steps. So first, defining the population of index admissions, attributing the episode to a clinician or clinician group, excluding clinically unrelated services, and calculating episodes observed cost, and excluding episodes if necessary. Number 5 is then calculating expected episode costs or risk adjustments, and then finally calculating the measure score. You can see an example of the calculations in the image provided, and you'll notice the double asterisks that indicate the total number of MSPB episodes attributed to all individual eligible clinicians. The next measure is the TPCC, or total per capita cost. The TPCC measure focuses on primary care and evaluates the overall cost of care delivered to a patient. The TPCC measure is an average of per capita costs across all attributed patients and includes all Medicare Part A and B costs for 1 year following the identification of a primary care relationship. The measure is attributed to clinicians using the 4 steps: identifying candidate events based on the occurrence of certain primary care services that indicate the start of a primary care relationship; 2, applying service category and specialty exclusions to only include specialties and clinicians providing primary care; 3, constructing risk windows during which a clinician could reasonably be held responsible for the beneficiary's treatment costs; and 4, attributing beneficiary months that occur during a risk window and the performance period to TINs and your NPI. So the TPCC measure is expressed as a dollar amount, right? It's calculated by dividing each TIN and TIN NPI's average risk-adjusted monthly cost by their specialty adjustment factor. This results in a ratio. This ratio is then multiplied by the average, non-risk adjusted, and observed cost across the total population of attributed beneficiary months to convert the ratio into a dollar figure. Patients are excluded from the TPCC measure if they had a primary payer other than Medicare for any months during the performance year. They're also excluded if they weren't enrolled in both Medicare Part A and B for every month of the performance year, unless part of the year's enrollment was the result of a new enrollment or death. They're also excluded if they reside outside the U.S. or its territories during any month of the performance year. And you're also excluded if they are covered by the Railroad Retirement Board, their date of birth is missing from data sources, or if they died before the start of the performance period. And specialty adjustment is applied to the TPCC measure to account for the cost of variation across specialties, and TINs and specialty adjustment is performed at the provider level. Okay. So the case minimum for a TPCC is 20 patients. The clinician and groups will only be scored if they're attributed any month across at least 20 patients. And with regard to risk adjustment, a TPCC risk score is generated for each beneficiary month using diagnostic data from the 12 months immediately preceding each beneficiary month. And so, for example, to determine if the risk score for a beneficiary month of August 2023, the data from August 22 to July 2023 would be used. And then a patient's best score summarizes their expected costs of care relative to other patients. The TPCC measure is calculated in 5 steps. So first we calculate the payment standardized monthly observed cost, then we calculate risk scores and risk-adjusted monthly costs. Then a specialty adjust monthly cost, then we finally calculate the measure score. And when calculating the TPCC, the numerator for this measure is the sum of all risk-adjusted payments, standardized and specialty adjusted Medicare Parts A and B costs across all beneficiary months, attributed to a TIN or TIN NPI during the measurement period. And then the denominator for the TPCC is the number of beneficiary months attributed to a TIN or TIN NPI during the measurement period. The TPCC measure score is expressed as a dollar amount. It's calculated by dividing each TIN and TIN NPI's average risk-adjusted monthly cost by their specialty adjustment factor, resulting in a ratio. This ratio is then multiplied by the average observed cost from the total population attributed beneficiary months to convert the ratio to a dollar figure. Remember, your TPC score measure score, which is expressed as a dollar amount, will be compared to the 2023 benchmark to determine how many achievement points the measure will receive, and this is between 1 and 10. Next, we have our episode-based cost measures. The acute inpatient medical conditions and procedural episode-based cost measures assess the cost of Medicare for the items and services provided to a patient during an episode of care. These types of cost measures only include items and services related to the episode of care for a clinical condition or procedure. Both procedural and acute inpatient medical condition episode-based measures are generally calculated with the following 6 steps. They trigger and define an episode, and episodes are defined by billing codes that trigger an episode, and episodes may be placed into mutually exclusive and exhaustive subgroups for meaningful clinical comparison. 2, they attribute episodes to a clinician. 3, they assign cost to an episode and calculate total observed episode costs. 4, they exclude episodes, measure specific exclusions, which remove unique groups of patients from the measure in cases where it may be impractical or unfair to compare the costs of caring for these patients to the cost of caring for the measure's cohort as a whole. 5, they calculate expected episode costs through risk adjustment, and 6, calculate measure scores. For acute inpatient medical episodes, an episode is attributed to clinician groups or TINs that bill at least 30% of an inpatient E&M claims during the trigger inpatient stay, and to individual TINs or clinicians or TIN NPIs who bill at least one inpatient E&M claim line under a TIN that met the 30% threshold. And for some episode groups, additional codes aid in determining the attributed clinician. And for procedural episodes, they are attributed to the clinician who built a trigger code for the episode group. And for clinician groups, episodes are attributed by aggregating all episodes attributed to clinicians that build to that clinician group. We have provided this list of 15 available measures for you to review for the episode-based measures. Acute inpatient medical condition episode attribution includes all TIN NPIs who bill at least one inpatient E&M service within a TIN that met at the 30% threshold will be attributed to the episode. As a result, an acute inpatient medical condition episode can be attributed to more than one individual clinician. CMS doesn't exclude episodes if a patient already qualified for another episode. The case minimum requirement for acute inpatient medical condition episode-based measures is 20, meaning 20 episodes must be attributed to a MIPS-eligible clinician or group for the measure to be scored. For groups, a total of 20 acute inpatient medical condition episodes must be attributed across all clinicians who have reassigned their billing rights to the group's TIN. Procedural episode-based cost measure attribution includes the case minimum requirement for procedurals, which is 10, meaning 10 episodes must be attributed to a MIPS-eligible clinician or group for the measure to be scored. For groups, a total of 10 procedural episodes must be attributed across all clinicians who have reassigned their billing rights to the group's TIN. So to calculate these, we have to trigger and then define an episode. And so episodes are generally defined by the billing codes that trigger an episode, and they may be placed into mutually exclusive or exhaustive subgroups for meaningful comparison. Next, we attribute episodes to a clinician, and then we assign the cost to an episode and calculate total observed episode costs. And we have the exclusions. So measure-specific exclusions remove unique groups of patients from the measure in cases where it may be, impractical or unfair to compare the cost of caring for these patients to the cost of caring for the measured cohort as a whole. Then we calculate the expected episode costs through risk adjustment, and then finally calculate the measure scores, which brings us to our final measure today. Finally, we have the chronic condition episode-based cost measures. So these measures are constructed and calculated via the following 8 steps. The first is to identify patients receiving care. Next, we identify the total length of care between a patient and the clinician group. Third is to define an episode, and then we attribute the episode to the clinician group or clinician. Next, we assign costs to the episode and calculate the episode's annualized observed costs, and we exclude episodes. Next, we calculate the annualized expected cost for risk adjustment, and then the score is calculated. So there are 2 chronic condition episode cost measures available in 2023, and these are the diabetes and then asthma/COPD measures. Both of these measures have a minimum episode window of 365 days, which brings us to the case minimums for this measure. Clinicians and groups will only be scored on the measure if they are attributed at least 20 episodes for both of these chronic condition measures. So chronic condition cost measures have the following exclusions. They're excluded if the patient is a primary payer, has a primary payer other than Medicare for any time overlapping the episode window or the 120-day look-back period prior to the episode window. There's an exclusion if the patient wasn't enrolled in Medicare Parts A and B for the entirety of the look-back period, plus one or plus one episode window, or if they were enrolled in Part C for any part of the look-back period plus episode window. There's also exclusions if the patient wasn't found in the Medicare enrollment database, if the patient's death date occurred before the episode end date, and if the patient resided outside of the U.S. or its territories during the episode window, and also if the patient has an episode window shorter than 1 year. And those are all of our cost measures available for 2023. I feel like if I say episode 20 more times, it might sink in. So I'm going to hand it over to Lindsay to further review costs for reporting and scoring.
Perfect. Thank you, Kimmy. That was an awesome overview of the cost measures. I know a lot of words and a lot of technicalities there. You know, I hope we all have an idea of which measures would apply to your practice, or at least understand the performance a little bit more. You know, again, based on your specialty, based on the patients you're seeing and the diagnoses they have and the episodes of care that you're treating. Again, we have some practices who, you know, none of the cost measures may apply to them in some way, shape, or form. And we have others, you know, really based on specialty, like I said, or the patients you're seeing or the services you're providing, who have, you know, a large majority, maybe even of those episode-based measures. Again, just depends on what you're seeing and what you're treating at this point in time. And if you meet the case minimum, the hard part to talk through today, I know, was really the attribution process. We did link those measure-specific forms that go through the attribution process for each specific measure. That's the key right there, is to understand how patients are attributed. So you would understand if, you know, your clinicians at your own practice, or if you're reporting as a group, you know, your tax ID as a whole, if patients would be attributed to your NPIs or tax IDs. Because if they are, then it's just if you meet the case minimum, and then, you know, you'd be scored on that. So moving on to reporting and scoring. First being, there is no reporting. I know we mentioned this, but CMS uses the Medicare administrative claims data to actually calculate your cost measure performance. So, you know, as participants in the program, you actually don't have to submit any additional cost data when you're reporting under either traditional MIPS, or again, we will mention MVPs here, since these are up and coming in 2023. So under traditional MIPS, you're going to be scored on each measure, again, that you meet or exceed that established case minimum requirement that we just went over. And it is different for every measure. And then each MVP, we'll just mention this here since I know we were focused on traditional MIPS, but each MVP does include cost measures that are going to be relevant to the MVP clinical topic or episode of care. Obviously, there's you know, an MVP for chronic conditions. So, you know, I would assume diabetes would be included in that, and/or asthma, COPD. But with the MVP, CMS is going to calculate your performance exclusively on those cost measures that are included in it, for which, again, you meet that established case minimum requirement. Even if, and here's the kicker, which is good news for us, even if additional cost measures, maybe outside of your selected MVP, are available for scoring, they will not score you on that. You're only scored on the cost measures included in that value pathway. The APP or the APM pathway, this actually does not measure cost performance. You get a pass here. So if you don't know what the APP is, we did briefly review it in our last webinar on the improvement activity category, but it's essentially just another avenue or pathway to report under MIPS for this program. Now, the concept of not having to actually report anything to CMS is both good and bad. I would say it's good since we don't have to worry about it, right? When we go to submission time, we don't have to send anything to CMS. It takes the administrative burden off of us. However, it's bad because we also have no visibility into performance throughout the year, at least how the program stands now. You know, we don't know how you're performing on any cost measures right now, or what patients are attributed to you, or, you know, where you stand with the case minimum right now. We don't have visibility into that. So good and bad. Now, again, if we focus on traditional MIPS reporting, since that was the intention of these category kind of deep dives here, how exactly does scoring work for cost just overall, which I know we kind of touched on as well. But again, for a cost measure to be scored, you have to meet or exceed that case minimum. If you're looking at all these measures and you're really overwhelmed, if you aren't performing a knee replacement, that measure is not going to apply to you. So really just try and focus on what measures would actually apply to you, and if you see over that threshold of 30 or 25 or 10, whatever that is. If one cost measure can be scored, the measure score will be used to compute that performance category score. If multiple cost measures can be scored, you're actually going to be scored on the equally weighted average of the points assigned to the scored measures. So unlike our other categories, we've seen different measures aren't weighted at different weights. TPCC isn't weighted higher than an episode-based measure. It's the equal average of your score out of 10 points for each measure that will give you your total category score if you qualify for more than one measure. If no cost measure can be scored, costs will count for 0% towards your final score, and CMS will basically reweight that performance category, that 30%, to either one or a few different categories. It depends on your practice size. And we have seen this happen a lot, so I wouldn't be surprised if you're super specialized and some of those episode-based measures don't apply to you yet. Again, it may be 0%. They also have been adding to those episode-based measures year after year. We saw new ones added in 2019, and we saw new ones added in 2020. Now, what does this really look like in real life over the last few years? After kind of all that information on the requirements, all that technical verbiage, the measure specifications, the exclusions, the attribution, and the scoring, we really wanted to end today's presentation on basically a leveling with you on what all is happening in this category. So basically the cost category has been reweighted to 0 for most of the years MIPS has been around. The first year, 2017, it wasn't scored because it was a transition year. However, since 2020, it has not been scored due to the pandemic. So this means there have been no feedback reports for providers to view their cost performance and determine what measures have even applied to your practice and how you stack up. And even if you got a feedback report for the 2 years it was scored, many of the episode-based measures were added, like I just said, in 2019 or 2020. So they won't be included. The 2019 ones would be, but again, any of those new ones added in 2020 wouldn't even be on that feedback report. So without these feedback reports, it's very difficult to understand how your practice is scoring. And with costs now being worth 30% of your final score, this is a huge chunk to have no visibility into. We hope with the proposed rule expected to be released over the upcoming weeks, there will be mention of cost reports. Otherwise, again, the best advice we can provide currently is to try and, obviously review the measures and see which ones you think would apply to you. Review those attribution guides to see what in your patient population could be attributed to you, but also kind of go back deep in the archives if you have them and see if you can find your QRUR report. It's called your Quality and Resource Use Report from your old value-based modifier days, that old program, as some of these measures came from there and may be able to give you a better idea of how you were performing. Again, you are compared to your peers for the current performance years. So we are not sure, what the benchmarks are until they release the final, like I said, final scores or final feedback, but it could give you an understanding of where you currently lie for each one of those measures that was included on the QRUR report. Also keep in mind for this year, they did release that COVID-19 hardship we talked about. This is likely, I would say, the last time for this EUC to be around, and you can claim that EUC for this category. And that would, again, take that unknown out of the equation. We just aren't sure if you do claim that EUC for the COVID-19 hardship for cost, if you'll receive a feedback report or not, hoping for additional guidance, like I said, in the upcoming proposed rule that should be released. So if you are feeling hesitant or overwhelmed, not just with cost, because I think that's a guaranteed here with the amount of ambiguity that we're seeing with this category, but if you were able to attend our other sessions on the MIPS and CHIPS Lunch and Learn series that we had, please just know we're here to help you. This is our full-time job, and I'm sure for most of you on the line, it's not. And the good news is you don't have to do MIPS alone. Our team is here to help you. We have all kinds of assistance packages to best suit your needs. We can provide you ongoing assistance, or we can provide you as needed assistance. These are going to be completely customizable packages to what you need. We can help you start to finish with everything. We can assist with your data analysis, report retrieval, do any sort of measure training for quality or PI, looking at documentation or workflow training. We always offer performance analysis with specific action items to actually improve your score over time. Assistance with submission, whether it be through your EHR, through a registry, or if you want to do it through the QPP website, we've got experience with it all. And of course, audit guidance. We just completed our first round of audits for clients in 2023 as well. We love to meet with you on a regular basis, typically monthly, but it really is your preference on how often you want to meet or if you want to meet. But we'd like to review your data together and work together to improve your overall performance. We're also willing to teach your practice. If you have a resource or a team, teach you all to be experts on the program with a goal to bring it in-house in the future. Really, any way that we can help you, we're here to do so. BAS can not only also make MIPS easier, but we can also potentially help you improve your cost score by utilizing one of our virtual care service options, remote patient monitoring, or RPM, as well as chronic care management or CCM, right? If you've got healthier patients, you know how they're doing proactively throughout the month, you'll be able to treat them and lower their overall costs related to their care. So both of our solutions have $0 upfront cost. We provide you with a list of eligible patients at your practice, and then we gain your approval to reach out to them and enroll them in either program. Again, there is with these services a monthly requirement to meet with a patient or update their care plans, and then especially take vital readings. This is all handled by our care coordinators and uploaded directly into the patient's chart in your EHR. This is not an additional burden on your practice. We take care of it all. And then each month we provide a list of patients and what you can bill for them. So we track what criteria they met to make sure you're safe for an audit and what you're allowed to bill. So again, all about increasing your reimbursement and providing better care, help you meet MIPS criteria, help you improve your cost score, help you meet PCMH criteria, and really overall provide better care to your patients, which is what it's all about. But our team also manages these services as well. So don't hesitate to reach out if you have any questions or want to learn more about RPM or CCM. And that is it. We made it. So if you are asking yourself what your next step should be, absolutely visit our website to learn more about any of our services. Continue to sign up for our webinars, especially the ones we have coming up, especially the proposed rule one should be a really big one, coming up over the next few weeks. And then, of course, like I said, if this felt overwhelming, if you have additional questions afterwards, or you want another set of eyes looking at your data, consider working with our team to offer guidance. You would be working directly with myself, Kimmy, or Bridget. Just reach out if you're a current DAS customer to your account manager, or if you don't have one yet, you can email us directly. And here's our contact information here in Kimmy's beautiful face. Don't hesitate to reach out. We did, of course, want to open up the floor to questions from you on the cost category. We know this is a very high-level approach, so if your head's spinning a bit and there are no questions, or you have one after the fact, again, feel free to shoot us an email here and we'll respond to it. But I will go ahead and, Bridget, Kimmy, are there any questions in the question panel right now, or we can give everyone a minute or two to get them typed in?
Yeah, I'm not seeing any right now. Like you said, it's a lot of information to absorb. So, but as of right now, there are no questions. Okay.
I will take it that we were just so thorough, or we use so much jargon, potentially. We have people's heads spinning right now. And again, it is really the nature of the category, to try and bring it down to simpler terms really wouldn't do each measure justice. Each measure has its own unique attribution process, exclusions, et cetera, that we needed to cover here. But again, if you have any follow-up questions or you want to learn more, please, like I said, jot down that governmentincentives@dashealth.com email address. We are happy to help you. With that, with no questions, we kept this one short and sweet today. Like I said, keep your eyes peeled for upcoming webinar invites or follow our LinkedIn page to see more updates. Other than that, thank you all so much for joining today, and we look forward to seeing you on a future webinar.